So now I would like to hand over to Dr. Rabbani. Please, Doctor.
Thank you for giving me the opportunity. I was going to wait for a little bit for people to let in, but I want to make sure that we have enough time for everybody for their presentation. So I'm gonna go ahead and start it. So welcome and thank you very, very much to everyone in attendance today. I'm Dr. Rabbani Khan, a graduate from Bangladesh FETP program, and currently I'm working in the Ministry of Health and Family Welfare Bangladesh, and I've been posted as a senior scientific officer at Institute of Epidemiology, Disease Control and Research, IEDCR, which is the only epidemiological institute in Bangladesh. And I'm very proud to serve as a moderator in this presentation session. Today, in this session, we have 4 presentations on different perspectives of COVID-19 disease. And I know everyone present here is excited to listen from the speakers. I would like to outline how the session will move forward. The speakers will have 10 minutes each for their presentations, followed by 10 minutes for questions and answer session. May I kindly request all the participants to mute their microphones if you are not speaking. And if you have any question, you can ask at the end of the session. And alternatively, you can also write your questions in the chat room of Google Meet or YouTube. And one small request, please provide your name and agency along with your questions when you are asking questions in chat rooms. Without further delay, let's move on to the presentation. I would like to request our first speaker, Dr. Ajan, who is from EIS South India, to give away the presentation on epidemiology of COVID-19 in Kerala State, India 2020.
Good morning, everyone. Am I audible?
Yes.
Good morning, all of you. I'm Dr. Ajan MC, cohort 2 scholar from India, EIS South in National Institute of Epidemiology, Chennai. I'm currently working in the Directorate of Health Service and in the State COVID Control Room, Kerala. Today, I'm going to present to you on the epidemiology of COVID-19 in Kerala. Next slide, please. Let me bring to you how the whole event unfolded. It all began as a cluster of pneumonia cases of unknown etiology in Wuhan city of China. And slowly the disease left the mainland China and started appearing in nearby countries. And it reached the Indian subcontinent by January 30 in the Thrissur district of Kerala. Next slide, please. And by October 31st, 45 million confirmed cases of COVID-19 have been reported worldwide, including 1.1 million deaths. Next slide. Before going into the setting, let me introduce you to the state of Kerala for all who may not be knowing. It is a state on the southwestern Malabar coast of India with more than 34 million population and population density of 890 per kilometer square. The state also has a high human development index of 0.78 with 12% elderly population and a significant immigrant population of more than 2.1 million. All these factors are very important in predicting the course of infection. Next slide. And as on October 31st, the total cases reported in Kerala is 0.43 million and compared to India with 8.1 million. Next. And the active cases as on October 31st in Kerala was 0.09 million and in India was 0.58 million. Next. The objective of my study was to describe the epidemiology of COVID-19 in Kerala, India during January to July 2020 by time, place, and person. Next slide. We did a cross-sectional study on all the confirmed COVID-19 cases in Kerala from January to July 2020 using the state surveillance data, which is cleaned and analyzed using EpiInfo version 7.2.3.1. Next slide. Before going into the result, I would like to describe further a little bit about the COVID-19 surveillance system in Kerala, which is established. For a traveler coming to Kerala or a contact of a positive case, they have to remain in home quarantine for a period of 14 days. And if turned symptomatic, they have to get tested at the labs. And if turned positive, they will be admitted to either COVID hospital for COVID first line or second line treatment centers, or they can opt for staying at home or domiciliary care center for a period of 10 days, following which they will get tested. Admission to these facilities are based on the severity of symptoms and comorbidities. Next slide. Over the period, the surveillance system has undergone several changes. And after establishing the surveillance system for COVID on Jan 24, the testing guidelines were changed by including returnees from countries notified by World Health Organization. Then public health mitigation strategies such as break the chain campaign, universal usage of masks were implemented during the month of March and April. And sentinel surveillance was testing was established from May 14, and antigen testing was introduced from July 2nd onwards. Next slide. The case definition which we adopted was for a confirmed case of COVID-19 was a person with laboratory confirmation of COVID-19 by either RT-PCR, TrueNAT, or rapid antigen testing, irrespective of clinical signs and symptoms in Kerala. Next slide. On analyzing the study population, the median age was found to be 35 with an interquartile range of 25 to 48. 77% of the study population was between the age group of 20 to 60. 68% were males and 41% were travelers and 3% were healthcare workers. Contact tracing process was also expeditiously done and was able to trace out an average of 7 persons per case. 111 deaths also occurred during this period from the study population, and with a case fatality rate of 0.4%. And the cumulative sample positivity was 3% at July 30. Next slide. An epi curve was plotted to show the time distribution by date of reporting of cases. 3 cases were confirmed during January and February, and then again the cases started appearing on March first week, and till lockdown was enforced on March 24. And after the lockdown relaxations were implemented, permitting interstate and travelers and repatriation flights to come, cases started increasing, and further rapid increase occurred after sentinel surveillance was expanded and antigen testing was enforced. Next slide. The incidence in administrative districts were also calculated. Initially, in almost all districts, it remained below 100 during the month of May and June. But in the month of July, in the border sharing districts like Thiruvananthapuram, Pathanamthitta, and Kasaragod, the cases and incidence went beyond 1,000 per million. Next slide. Age-wise attack rates was also calculated and was found to be 990 and 801 in age groups of 20 to 40 and 40 to 60 respectively. In males, the incidence was more than twice as compared to females. Next slide. The probable source of infection was also found out, and it turned out to be 40% travelers and 54% contacts. 5% of the cases had no contacts or travel history traced at the time of declaration. The districts were arranged in the descending order of traveler history in the graph plotted here, and it was different in different districts, and Palakkad had the highest proportion of 70%. Next slide. The reported symptoms among the COVID-19 cases at the time of admission was also analyzed, and it was found that 27% of the cases had fever, followed by cough and sore throat, and 24% of the cases were asymptomatic at the time of confirmation. Next slide. Another point to mention was on cases which presented with a single symptom or the only symptom to be presented at the time of admission, fever was the most common symptom in 35% of the cases, followed by breathlessness, nasal discharge. Next slide. The mortality or the deaths which happened were also analyzed, and among the 111 deaths which happened, 103 had comorbidities, and among the comorbidity, diabetes was the major contributor with 56%. Case fatality rate was also calculated and is found to be 3.45% among more than 60 age group, and with a total case fatality rate of 0.47. There was not much of a difference between the case fatality rates of males and females. Next slide. Doubling time was also calculated, which is hovering around 14 to 16. And hospital infrastructure and ICU beds were planned based on these doubling rate predictions. Next slide. The COVID-19 test by method of testing was also plotted to find out how the testing method changed. Initially, for the 0.7 million tests done till July 31st, the number of tests done per day was initially less than 1,000 and was mainly RT-PCR, and it later got shifted to antigen, as you can rightly see from the graph. Next slide. The distribution of COVID-19 cases, daily persons tested, and test positivity was by date of reporting was plotted, and a component bar chart was made with log to the base of 10. And we could see that the test positivity was fluctuating and from 1 to 6, but lately showing a steady upward trend and should be focused upon as a predictor of the future increase in cases. Next slide. Moving to the conclusions which we arrived upon from our study, the proportion of cases with contact history and unlinked cases were increasing after the travel resumed after lockdown and sentinel surveillance was increased. The incidence of COVID-19 was highest in border sharing districts. The testing capacity was scaled up first by increasing RT-PCR and later by antigen testing. And the incidence of COVID-19 was higher in 20 to 60 age group. And point worth mentioning was mortality was higher among persons with comorbidities and in elderly population. Next slide. The recommendations which we arrived at are as follows. That is, to increase the community testing in areas where clustering of cases or unlinked cases are found, and case investigation and contact tracing need to be intensified, and data on high risk and low risk primary is not available at present need to be collected. EC and BCC should be focused on the 20 to 60 age group, and strict preventive measures should be followed by this group, as they can bring the disease to the vulnerable population at home. And let me remind you, Kerala is having an elderly population of more than 12%. And reverse quarantine need to be ensured among elderly and those with comorbidity to prevent such mishap. Next. With that, I would like to conclude my presentation and would like to thank my mentors and faculty at the National Institute of Epidemiology, my colleagues at COVID Control Room State, and the conference organizers, my Director of Health Services and Health Secretary for the wonderful opportunity they have all provided. Thank you once again.
Thank you, Dr. Ajan, for sharing the distribution and magnitude of COVID-19 disease in Kerala, and also stating the importance of surveillance in prevention of infectious disease like COVID-19. The floor is now open for question and answer session. So if anyone wants to ask any questions, we have some couple of questions in the chat room, but I will go if there are any questions from the participants. Okay, I think let's go with the questions in the chat room. So first question for Hari Shankar. So his question is there any advantage of community isolation compared to home isolation? Dr. Ajan.
Yes. Home isolation and community isolation, I didn't get. Can you please elaborate on that?
So is there any advantage of community isolation compared to home isolation?
Okay. For home isolation, we could found that most of the persons, those are having capacity to be at having a home isolation, they would prefer to stay at home because all the surroundings and all are familiar to them. And the surveillance which we established was that daily calls were made to them to ensure their health status. And if at all they are having any symptoms, they were asked to report, and an ambulance was provided to them to bring them to the health facility. And it was not advisable for those who were having any comorbidity at the time and uncontrolled comorbidities, like, for example, diabetes and hypertension. If at all that was the case, they were not allowed to be in home isolation and they will be shifted to COVID first-line treatment centers. Thank you.
Okay, thank you so much. So another question from Dr. Kayati from India EIS. Were all travelers from outside quarantine for 14 days?
Yes. And all, it was like the system we established in the state of Kerala was all those who want to come to Kerala, they had to register first in a portal named COVID-19 Jatudha. And if at all after registering in the portal, a pass which will be issued, and with that pass only they can come to Kerala. And after that, the rapid response team at the local self-government level were ensuring that they were sticking on to home quarantine and all.
Okay. So there's another question. So what is the meaning of reverse quarantine? A question from Hansa Varakul.
It is like a quarantine is what we use for those with at risk, for those who are suspected to be having an infection. And reverse quarantine was defined for those who are comorbidities, elderly persons. They should also be protected and should be isolated from the disease which was circulating outside. That was which we used and which we promoted with IEC in state of Kerala, and it has quite worked well.
Okay. So, so moving on to the next question, it's from Meng Yu Chen. So interestingly, he wants to know that see the difference in the incidence by gender. Do you think it's because of the biological factor or due to the access to testing? Any difference in test positivity rate by gender?
It is actually because for the initial period, all the returnees and all were migrant workers and all outside. Most of the cases, as you can see, 40% of the cases were travelers. And during that period, most of the returnees were males also. And that's the reason why it's actually fluctuated. And Kerala being a highly literate state, and also with everybody having an access or accessibility to test at cost, people can go and test. And there is no difference in gender, so that male can test only, something like that.
Okay. So next question is, when was the first unlinked case identified? And will that count as community transmission? It's from Purvi from India.
The first case, as I already mentioned during my presentation, the unlinked cases of our 5% unlinked cases, which you say, that is at the time of declaration of the case. And we have done extensive investigation to find out whether there are any linkages to the cases. And we could, for the initial part and all, we could find most of the cases to be linked to some case or other. And the initial unlinked case was reported, or which we couldn't trace to something, was around April, May.
Okay.
But
So,
as a point was community transmission was raised, what we did to ensure or to examine the possibility, we tested all the contacts, all the possible contacts of those cases, and we couldn't expand the case count from that. And that's why for the period of May and June and all, community transmission was not different.
okay, thank you. So another question from Angela Huang from Taiwan FETP. So how did you decide who gets PCR testing and who gets antigen testing? And did the positivity rates differ?
Yes, it's like as already was present in the slide. Can you take me to the slide 20? Hello? Yes. Slide number 20, please. Yes. As you can see, antigen testing was introduced in the month of July. Until then, we had RT-PCR and TrueNAT testing. And TrueNAT testing was employed for emergency surgeries, deliveries, and all. And antigen testing was more or less be done at the community areas where more and more cases started reporting to rule out community transmission and all. And all the symptomatic, if at all a symptomatic case is negative in antigen testing, that person will be subjected to RT-PCR testing. And as mentioned, RT-PCR had more positivity because it was done more on high-risk suspects.
Okay, we are running out of time, so we have so many questions in the chat box. So I think I will take one or two. So one question from Bina Rai: did you have enough resources to make sure that all complied to the quarantine? And what happens if they break quarantine? And what do you know about it? So
it's like what we ensured was initially it was advised that all those returnees should be placed at institutional quarantines. I mean, we had set up institutional quarantines at all districts. But later, we found that, as already mentioned, the number of returnees are by and large very huge in Kerala compared to other states and all. And people were very wanting to be at their homes. Many of the persons have got good facilities for ensuring room quarantine or home isolation at their residences itself. So it got shifted to that policy decision, and people were allowed to be in home quarantine. And those who broke home quarantine or broke the laws of quarantine, Epidemic Act was enforced in Kerala, and as in all over India. And cases were actually taken against them. So people had such sort of fear also. So most of them, we had very few instances of quarantine breakage. Yes, thank you.
okay, so Dr. Ajan, I think you can also access to the chat box. So it would be great if you can answer those questions in the chat box. That would be great. So one last question from my side: that how did you actually define the contacts in the study?
Like the contact definition which we used to was adopted from the World Health Organization and also ICMR. And right from the beginning itself, we had contacts definition like high-risk primary contacts and low-risk cases. Like contacts with a confirmed case of COVID-19 or a traveler with who visited a hospital where COVID-19 are being treated, or where a place where local transmission is being reported, or who touched body fluids. Those were categorized as high-risk cases. And low-risk cases were like shared the same space, an open space, travel in the same environment, but not having high-risk exposure, like that.
Okay, thank you, Dr. Ajan, for your answer, and thank you all for your lively participation. I would like to request Dr. Ajan to respond to the questions raised in the chat box, please.
Okay, with pleasure.
Thank you. So moving forward to our next presentation on effectiveness of airport screening for COVID-19 at Taiwan International Airport, January to June 2020. This will be presented by Ching-Yuan Tseng from FETP Taiwan. Pardon me if I pronounce the names incorrectly. So dear audience, Ching-Yuan Tseng from Taiwan FETP.
Good afternoon, Nest. In response to COVID-19 pandemic, many countries have conducted travel-related countermeasures to contain the transmission of Entry screening are measures conducted at the point of entry on travelers arriving to a country to assess travelers' risk of having COVID-19 and prevent disease introduction to the country. Activities include observation of travelers' symptoms and signs, temperature measurement, health quarantine, lab examination, and ordering isolation, quarantine, and travel restrictions. Next. Several COVID-19 measures have been taken at the Taiwan border. Next. When COVID-19 outbreak emerged from Wuhan, China, Quarantine officer at the airport conducted on-board health assessment for all flights arriving from Wuhan. Next. Since January 24, all passengers arriving from COVID-19 high-risk country are asked to complete a health declaration card. They are also subjected to a 30-day post-entry quarantine. Next. Since February 6, travelers who were suspected to have COVID-19 would get tested on-site at the airport. Before then, travelers were sent to hospital for sampling. Next. As COVID-19 spread across the world, high-risk countries have updated several times. At first, it included Wuhan, then expanded China in late January, and then to Asia, Europe, and Americas in late February, and to all countries since March 19. Next. Here is the entry screening and quarantine process. At the point of entry, passengers arriving from COVID-19 high-risk countries need to complete a health declaration card to report COVID-19 related symptoms or possible contact. Thermal scanners are set to detect feeble passengers. Next. Quarantine officers then assess passengers who report symptoms or are feeble and determine if passengers meet the case definition current at that time. Next. Those who do not have symptoms, do not meet the case definition or test negative, will undergo self-management for quarantine for 40 days. Next. Those who do not have symptoms do not meet the case definition for test negative, will undergo self-management or quarantine for 40 days. Next. The case definition for suspect COVID-19 cases has changed over time. In January and February, the clinic criteria was fever and respiratory illness. Later, it changed to fever or acute respiratory illness. In late March, GI illness, abnormal smell or taste were added. In January, China was the only epidemic area. In February and March, high-risk countries include countries in Asia, Europe, and the Americas. Since March, all countries in the world are considered high risk. Next. The case definition for confirmed case COVID-19 cases is a person who tests positive for SARS-CoV-2 RT-PCR at the point of entry or after entry to Taiwan. Next. Our objective is to evaluate the effectiveness of entry screening for COVID-19 at the Taoyuan Airport, which is the largest international airport in Taiwan. Next. We use the data from the National Quarantine Surveillance System. We extracted data of all inbound passengers at the Taoyuan Airport during January 1 to June 30, and their data of arrival, symptoms, and PCR testing result. We calculate the case detection rate, sensitivity, and possible predictive value or PPV of airport screening and examine the change by month. Next. Case detection rate was calculated as the number of confirmed cases of COVID-19 detected at the airport per 1,000 passengers screened. Sensitivity was the number of confirmed cases detected at the airport as a proportion of the total number of impacted cases. PPV was the proportion of symptomatic cases who tested positive for COVID-19. Next. During the study period, nearly 2.9 million passengers arriving at Taoyuan Airport. Next. Over 10,000 had symptoms. Next. 6,047 meet the case definition of suspect cases and testing for COVID-19. Next. Passengers who had no symptoms or do not meet the case definition were non-suspect. They passed through the airport without testing. Next. Of the 6,047 passengers tested, 131 passengers were confirmed case to have COVID-19. Next. The overall case detection rate of screening of 0.05 per 1,000 passengers. Next. The case detection rate increased in March and peaked in April, when countries in Europe and Americans experienced at the first wave of COVID-19. The case detection rate decreased after. Next. Additional 218 imported confirmed cases passed through the airport without testing, but were detected during home quarantine. Next. As a result, the sensitivity of entry screening for COVID-19 was 37.5%. Next. Sensitivity increased from 10% in February to 88% in May. Repeated adjustment of the case definition during February and March may lead to increase in sensitivity. Next. Of the 6,047 suspect cases, 131 was confirmed as COVID-19. PPV was entry screening was 2.2%. Next. PPV varied by month, a range to 0.2% to 20%. The PPV in January was the highest, probably due to smaller number of passengers from Wuhan, China, but a high prevalence of COVID-19 impacted passengers from Wuhan during that time. Next. In summary, almost 2.9 million passengers underwent entry screening at the Taoyuan Airport during January to June 2020. We detected 131 COVID-19 confirmed cases through the screening. We find the airport screening for COVID-19 had moderate sensitivity but a low PPV. Next. Our study has a limitation. First, passengers' health status was self-reported, so there is a potential record and response bias. Second, not all passengers were tested at the point of entry. We may miss some asymptomatic or pre-symptomatic cases. Next. Our recommendation include to continue entry screening at the airport, to continue monitoring sensitivity and the PPV of the screening, to identify cost-benefit or potential harms related to screening, and to set criteria for discontinuation or discalculation of screening. Next. Thank you.
Thank you, and congratulations on your presentation, Dr. Ching-Yuan Tseng. It's a very nice one, and it's very important to measure the effectiveness of the screening program in the airports, because although countries were affected most of the countries got affected through COVID-19 through the imported cases. So if we can strengthen this point of entry screening, then it will be definitely much more helpful. So moving on to the question and answer session, we had a question from Dr. Amit Razivan. So he's from EIS program in Chennai, India. So he wants to know that, can you tell something more about your national quarantine surveillance system? Dr. Tseng.
Hello, everyone. I'm Dr. Cheng from Taiwan CDC, and I'll help with the translation. So I'll speak to Dr. Chen in Mandarin and then explain the question, and then she will respond in Mandarin, and I will help with the translate into English. Thank you.
Okay. So I repeat the question, can you tell something more about your national quarantine surveillance system? So, am I audible?
Excuse me, may I have 检疫系统就是，我们在就是旅客入境的时候，我们就是会收集旅客的相关的症状资料之后，我们会将他的症状资料会进入在我们的系统里面。那之后这些资料就会上传到我们的系统。那当旅客进入到社区的时候，我们的社区的防疫系统就可以知道这个 case， 那我们就可以启动追踪。
So in terms of our national quarantine system, we collect data in terms of traveler symptoms or date of arrival, and also the country traveled. And because of COVID, we also collect testing results. And then all the data we'll put on our surveillance system, and we'll link to the another quarantine system, and then other passenger could be followed even after their entry.
Okay, thank you. So I will just wait for some more of the questions in the chat room. So in between them, I have a question for you. So definitely, airport screening is most important, and it involves a lot of resources that are used for other activities during the airport screening. So what condition would you recommend using a airport screening to prevent the importation of cases?
OK， 好，我们透过检疫的这个 screening， 我们能够知道，当旅客入境当下的时候是不是有症状。那他假如在境外有症状的时候，我们也可以及时去做拦检的动作。谢谢。
If I understand, the question is asking when and what time we would implement the entry screening to identify the imported case. So in Taiwan, we already have, because of the after SARS, we already implement the quarantine surveillance at the point of entry. And we also apply that system to detect other imported cases, such as, the imported disease like measles or dengue. So we apply that structure to detect COVID, the emergent infectious disease, and COVID-19. We do know this take a lot of resources. That's why we try to evaluate the effectiveness of these measures, and we found that indeed it already detect like more 30% of imported cases. So that still kind of have some value for this screening process.
Okay, thank you. So another question from Manikandas Nisan. Sorry. So was the positive predictive value analyzed by countries? And if yes, which country has the highest PPV?
May I have 37 slide? 目前我们就是找到的最多的国家就是英国，再过来是美国。那英国部分是占31%，那美国有26%。
So during the study period, which is January to June 2020, the most cases, imported cases, detected at airport are from United States and European countries.
Okay, so another question from Dr. Pormarzi from Australia. So do you have any explanation for the decreased sensitivity after May 2020?
他是问说什么时候，为什么3月以后的 sensitivity 会下降？5月以后的sensitivity 会下降。
I think after May, the number of imported cases decreased, probably because of the slowly down of the epidemic, of the global epidemic.
Okay. So going to the next questions. What the success rate of the few validated point of care testing vis-a-vis the high definition PCR testing methods in your country or even globally?
We have no used the POCT. We have used the RT-PCR test.
Okay. So one question from Myanmar is Dr. Tseng playing. What are the recommended factors to be considered for decision-making on relaxing entry screening on airport?
问说什么？怎么样让你决定要继续使用这个 airport screening 这样子？
你说要继续使用 screening？ 那我们是会监测我们的 sensitivity。好，我们就是会持续监测我们的敏感度跟我们的 detection rate。那假如我们的这些的数据是有持续上升的话，那我们还是会继续做我们的入境的筛检的部分。
We can see that 32. With the adjustment of case definition during the study period, we can see the sensitivity of the entry screening increase. So that's why we recommend to continue monitor the sensitivity and positive predictive value to see the effectiveness of screening. If we see the decrease of sensitivity, we may to evaluate why was that, and we also recommend to further investigate the cost benefits related to screening, because we do know that it takes a lot of resources, and it also depends on the country's context. Like Taiwan is an island, so there's a lot of imported case even at this moment. So we still think that entry screening, we still require entry screening to prevent the cases imported or even to prevent the imported case into our country.
Okay, thank you. For last question for you, did you collect data on travel purposes, and how did positive predictive value vary by purpose of travel from 1?
我们最常见的就是从在国外的念书的学生，或者是在境外工作的工作人士回台的。
Most cases, they work or study abroad, but we don't have the exact number. But we believe at that time, most people were working or studying abroad.
Okay, thank you so much, and congratulations once again, Dr. Tseng, for your nice presentation, and thank you all the participants for the good discussion. We would like to move to the next presentation. I think Dr. Ayu Naraswari and Nesa, are you there? Yes, I see you from FETP Indonesia. So she will be presenting on characteristics and determinants of confirmed, asymptomatic, suspect, and probable COVID-19 cases in Bali Province, Indonesia. Over to you, Dr. Ayu Naraswari Nesa.
Okay, yes, I'm here. Good afternoon, everybody. Thank you for the opportunity given to me to present my study entitled Characteristic and Determinants of the Confirmed Asymptomatic, Suspected, and Probable of COVID-19 Cases in Bali Province. I'm Putu Ayu Naraswari Nesa, in a team with Ana Agung Sagung Sawitri, who is my supervisor, and Iwayan Pujana, a staff of Local Health Department of Bali Province. Yes, please, next slide. Coronavirus disease 19 or COVID-19 is a global pandemic disease that's still threatening global public health. Indonesia is one of the countries in the world that affected by the disease, with more than 10,118 cumulative cases have been documented occurred. Of 34 provinces in Indonesia, most of them have been infected with the disease, including Bali. The cases of COVID-19 in Bali have attracted the global attention, as Bali is a famous for the tourist destination in the world. Until April 2020, more than 200 of the confirmed cases have been recorded, with 130 cases recovered and 4 dead. However, studies related on the COVID-19 in Bali are still limited. Yes, please, next slide. Therefore, this study aims to assess the characteristic of the COVID-19 infection in Bali by assessing the distribution of them and identify its determinant. Next slide. A cross-sectional study was conducted using secondary online published data input from January 19 to April 30, 2020, gathered from Department of Health Bali Province. Sample units used in this study were 459 persons who suspected and or probable COVID-19 infection confirmed by diagnostic PCR. Data of the characteristic, including the distribution, were descriptively analyzed, while the potential determinants were analyzed by using bivariate analysis with the chi-square test. Variables that have p-value less than 0.25 were then tested by using logistic regression for the putative determinant. Next slide. In this result, among the 9 regencies and a city in Bali, the top 3 of the areas distributed with the COVID-19 cases were Denpasar City, occupied 23.1% of the total samples, with 20% confirmed case and 21.5% negative. Then Buleleng Regency with 14.4% of the total cases and 10.6% diagnostically confirmed and 17.5% negative. Whereas Gianyar Regency had 13.3% of the total cases with 11.1% confirmed case and 15.1% negative. Next slide. In the characteristic of the COVID-19 cases in Bali, this study found that more male were infected than female, within 65.6% in males against 34.4% in the females. Range age of 26 until 35 years old had the highest incidence of the disease, filled with 37.3% of the cases. Meanwhile, in the occupation, cruise ship crew had 35.5% of the cases, whereas in the domiciles regency and city of the COVID-19 distribution in Bali. Next slide, please. Denpasar had the highest percentage with 23.1% compared to the other areas. Similarly, having a historic contact with COVID-19 case before had 41.8% compared to the other risk factor. Yes, please. Next, please, slide. From the confirmed cases, it is interesting to acknowledge that 73.2% of the suspected cases with COVID-19 related symptoms diagnostically negative infected with the virus, whereas 50.2% persons with the PCR positive test had no symptoms of the infections. Or the 59 confirmed case, 19 showed clinical symptoms and 162 without showing symptoms. Next slide. Based on the multivariate analysis test, the variables of occupation and risk had p-value less than 0.05. It means the putative risk factor of the COVID-19 were occupation, the cruise ship crew, and the risk having historical contact with the infected person or COVID-19 cases. Occupation of cruise ship crew were 8.119 more likely infected with COVID-19 than non-cruise ship crew, with P less than 0.0001. Additionally, someone who had contacted with COVID-19 infected person were 1.436 more likely having the infection than someone with the historical no contact. Next slide. In this discussion, the high proportion of COVID-19 in Bali is likely associated with symptoms and without symptom case. In addition, screening tests performed at the airport and tracing the cases might contribute to the high proportion of the case. Denpasar had the highest confirmed case. It's actually beyond of this study. However, the high density population in Denpasar may be one of the factors involved in the cases. The cruise ship crew is a risk factor. At this time, many international migrant workers have returned home since January 2020. At the airport, screening of migrant workers using rapid test was enforced, and if they were reactive, a confirmation test was carried out. In addition, all migrant workers were isolated in certain buildings. Another risk factor is having contact history with COVID-19 cases. All persons recorded in the website data is related to COVID-19, including the history of contact with confirmed cases. Awareness about transmission were not yet well developed in the community level. The limitation of the study are PCR limited and input data incompleteness that influence the limited variable being analyzed. Next slide. In this conclusion, it is conclude some characteristic of COVID-19 infection found in Bali, such as more men were infected found along in the study period. Majority of the cases were resident in Denpasar, Buleleng, and Gianyar. Denpasar had the highest confirmed cases of COVID-19. In some related cases, found cases with diagnostically confirmed infected had no symptom, while in some other cases also found the suspected cases with related symptom but negatively confirmed. Cruise ship crew and having historical contact with COVID-19 cases might likely be the risk factor of the infection in Bali. However, more studies and data required to assess more about the COVID-19 infection in Bali to have more understanding and knowledge related on this disease infection in the area. Next slide. That's the end of my presentation, and finally, thank you for your attention.
Thank you so much, Dr. Naraswari and Nesa, for your nice presentation. Yes, we had a good idea on the distribution and determinants of confirmed cases in Bali, Indonesia. And you raised the important point that as it's a tourist place, Bali, Indonesia, so there's more chance, more likely to be spread of infection. So we have some couple of questions. First question from, two questions from Dr. Masum Billah from Bangladesh. So first question is, what was the criteria for testing COVID-19 in Bali, Indonesia? Should I repeat you the question again?
Okay. What was the criteria for testing COVID-19? In Bali Province, data from the website were input from the Bali Provincial Health Office and District Health Office. The data in Bali Provincial Health Office were added from related laboratory data, the Bali Airport and Sanglah Hospital. However, data in the District Health Office were gathered from sub-district level primary healthcare and district level hospital in Bali. I have the data from the district level. I cannot speak English fluently. I invite my supervisor, Dr. Savitri, can help to translate what to tell the everybody.
Yes, sure.
Hello, Nesa.
Yeah, thank you, Dr. Savitri, to join this presentation. I have the question, what's the criteria for testing COVID-19? Jadi dari kemarin untuk kegiatan kita yang kita testing itu berdasarkan hasil dari orang yang suspek PDP, ODP, dan OTG. Jadi kita melihat kriteria untuk mengikuti COVID-19. Jadi dia ada kontak terhadap orang yang terkena COVID-19. Mungkin bisa bantu disampaikan, Dok.
Yeah. We tested everybody who have ever contact with the confirmed cases, even though they have or not the symptoms. So as long as they consider as close contact defined by the CDC and the MOH, so it should be at least 15 minutes within the within contact with the cases. It's considered as a close contact. Then they should be examined for the PCR test. That is the criteria. Thank you.
Thank you, Dr. Saitri and Dr. Nesa. So your next question in the chat room from Masum Billah. So was there any COVID-19 outbreak in cruise ship in Indonesia?
In Indonesia, I don't have the data, but in Bali, can I show the slide for the slide 6? Can I show the slide number 6?
May I request all others to please mute your microphone?
Okay, in the characteristic, the cruise ships are 163 frequency and have a 35.5% cases in the cruise ship crew. But in Indonesia, I don't know about the outbreak in cruise ship or not. But in Bali, for the 19 January until 30 April, I have the data like this.
Okay, I think the question is, so there is, we didn't identify any cruise outbreak in cruise ship in COVID-19 in Bali. So you have some outbreak, but the total, the table you showed that the cruise ship crew, so those are the outbreaks in the cruise ships, right?
Yes.
Okay. So moving to your next question from Eric. How did you handle missing data and could this have affected your results?
If I have a missing data, I close or I don't use. I have 3,017 data, and the data had a PCR test just for 159 sample, and then 208 with the positive cases, the confirmed cases, and 259 is a negative confirmed case. Dr. Savitri mungkin bisa dibantu, di luar data itu kita tidak gunakan sebagai sampel ya.
Yeah, may I add some information about the missing data? So even though we have around 3,000 sample, but actually in March to April we have a policy not to examine all close contact with the PCR test. So at that time, the policy is more to examine the people within rapid test, and if the rapid test is negative, then it's not being followed with the PCR test. Another thing is because the PCR test is very limited at that time, so even in the also the rapid test is quite limited at that time. So many people who already isolated, self-isolated or isolated in the, for example, in the building settled by the government is also not being examined by the rapid test. So the 3,000 is actually not only contain missing data, but also contain many people who are only examined by the rapid test and or not examined by rapid test, but only being isolated in the settlement building, something like that.
Okay. Thank you, Dr. Saitri and Dr. Nesa. So the last question from Thea from Philippines. So among the confirmed cases who were asymptomatic, did they remain asymptomatic or eventually presented a sign or symptom after being tested?
Can I show the slide number 8? Dr. Sawitri, mungkin ini maksudnya apakah dia terlihat gejala lagi setelah dites?
We can hear you. Can you unmute?
Oh,
Nesa mau menjelaskan atau saya menjelaskan?
langsung dokter aja dah, Dok.
Yeah, okay. So we have actually that we have the policy if someone being positive, then we have to follow up until 14 days before they can be released from the isolation. However, we don't have any data for follow up. So actually, we don't know whether the asymptomatic person then having a symptom after the follow up. Yeah.
Okay.
So yeah, we cannot answer the question. Thank you.
Got it. We got it. So thank you, Dr. Saitri and Dr. Nesa, for your nice participation, and thank you again, the audience, for their participation. So moving to our last presentation from Kasmira Maramag from FETP Philippines, and she will be describing COVID-19 cases in 3 detention jails, a case control study, Metro Manila, Philippines, April 2020. Dr. Kasmira Maramag.
Good afternoon. I am Maria Kasmira Maramag, FETP Fellow, and I'm here to present the findings on our case control study on COVID-19 cases in 3 jails in Metro Manila, Philippines, conducted in April 2020. Next. The Philippines is an archipelago with an estimated population of more than 108 million. Metro Manila is the capital and the epicenter of COVID-19 in the Philippines. On January 30, we reported our first confirmed COVID-19 case, which was followed by 2 more cases within a week. All were imported cases from Wuhan, China. A travel ban was imposed after. No new case was reported until March 6, when the 4th confirmed case was identified. On March 7, local transmission was confirmed by the Department of Health. On March 15, Metro Manila was placed on enhanced community quarantine. Except for essential workers, citizens were strictly advised to stay home. On March 17, ECQ was expanded to the rest of Luzon. However, cluster in communities and closed settings such as health facilities were reported. Next. Next. Na-disconnect yata. Wala. On April 18, the Department of Health Event-Based Surveillance and Response received clustering reports in jails A and C. 4 days after, we started epidemiologic investigation on the 2 jails. On the same day, Jail B reported clustering and was included in the investigation. Next. Our objectives were described case detection, specimen collection, testing, and referral to health facility among cases and close contacts, determine the magnitude of the infection, and identify risk and protective factors of COVID-19 infection. Next. For our methodology, we reviewed medical records, interviewed key personnel, conducted active case finding among personnel and PDL, and collected nasal and oropharyngeal swabs for COVID-19 confirmatory testing via real-time polymerase chain reaction. Next, we used the following case definitions. A suspect case is any jail staff or person deprived of liberty who is a detainee, inmate, or prisoner from 3 identified jails who had sudden onset of fever, any respiratory signs and symptoms, or diarrhea starting February 1, 2020. A probable case is a suspect case whose test result was inconclusive or equivocal. Next. A confirmed COVID-19 case is a jail staff or PDL with or without signs or symptoms who tested positive for COVID-19. A close contact is a jail staff or PDL who provided direct care for a confirmed COVID-19 case without proper protective equipment, or a person who had direct physical contact, lived, worked, or transacted in close proximity for more than 15 minutes with a confirmed COVID-19 case. Next, we conducted an unmatched case control study. A case was a confirmed COVID-19 case. In a control was an asymptomatic jail staff or PDL who remained asymptomatic throughout the study and or negative for COVID-19 confirmatory test. Next, for our results. Next. Management of jails are under the jurisdiction of Bureau of Corrections and Bureau of Jail Management and Penology. In January 2020, congestion rate was above 300%. Next. A single-size bunk bed placed 2 to 3 feet apart are shared by 4 PDL. PDL are allowed to stay in the common area from 8 a.m. to 4 p.m. They group together with their gang members. They fall in line for ration food and share meals. Jail officers make rounds at least 3 times a day to account for all prisoners. Next, we identified 235 COVID-19 cases from the 3 jails. There were 115 suspect cases and 120 confirmed cases. Next. Of the 120 confirmed cases, 67% were female. Ages were 20 to 83 years old. Most common signs and symptoms were fever, cough, and sore throat. 17% were asymptomatic. 42% had pre-existing health conditions, such as hypertension, diabetes, and asthma. Next. There were 6 deaths with a case fatality of 5%. Majority were males from the older age group. All died due to pneumonia. Next. This figure shows the epidemic curve of cumulative confirmed cases from 3 jails. Jails canceled PDL visitation on March 10 after local transmission was announced. On March 20, jails implemented lockdown days after ECQ was imposed. Only jail staffs on duty were allowed to enter jail and will not leave post until completion of 2 weeks duty, then followed by 3 weeks off. Next. PDL and nurses claimed an increase in fever and respiratory illness starting late February, but were not tested for COVID-19. There were no record of consultation. Only those with life-threatening conditions were allowed to be brought to the nearest hospital and tested for COVID-19. Some of these PDL tested positive on PCR, but results were allegedly not received by the jails. COVID-19 is a notifiable disease that should be reported to DOH within 24 hours upon detection. However, on March 27, cases were detected by GLC but only reported to DOH in mid-April. Next. This figure shows clusters in GLC. Gray represents jail staff and PDL in orange. Initially, there was no symptom screening was done for visitors and jail staff. Medical team in the infirmary was assigned to do daily screening of staff once lockdown was implemented. First reported case was a jail officer, marked as A. She receives PDL visitors and visit other offices for administrative tasks. She does not have a known COVID-19 exposure, but resides in a city where 400 confirmed cases were reported. She recalled assisting a PDL visitor with fever and cough and developed fever days later. She continued to visit other offices, including the infirmary, while symptomatic. Clusters were reported among medical staff, including the admitted PDL and PDL health aide in the infirmary, and among jail staffs monitored by the medical team. All medical staff claimed use of surgical or N95 masks, but gloves, gown, and goggles were limited. Next. One of the PDL who died and labeled as case B had the earliest known onset. He was taken care of cared of by his gangmates who tested positive at least 3 days. After 2 weeks, case B progressed to severe symptoms and was admitted at the infirmary isolation room. Next. We identified factors associated with COVID-19 infection. Our analytic study showed, next, 19 factors were associated to COVID-19 infection on bivariate analysis. However, after logistic regression, we identified that those who shared a meal were 19 times more likely, those with diabetes 11 times more likely, and in an enclosed space with a confirmed case 4 times more likely to have COVID-19 infection. The risk of COVID-19 infection was lower among those who took vitamin C, no history of smoking, and used alcohol-based hand sanitizer. Next. In conclusion, there was a COVID-19 outbreak in jails. Jails are closed settings where infection is introduced by individuals from the community, such as PDL visitors and jail staff. For these 3 jails, there were no strict implementation of health and exposure screening of any individual entering. Transmission was sustained due to poor practice of minimum health standards, such as masking, physical distancing due to overcrowding, hand hygiene, and PPE for healthcare workers. Limited testing and late reporting led to the delayed detection of cases and contact tracing, causing clusters to emerge. Next. We recommended the following adapting the Philippine COVID-19 response. Prevention and control measures such as use of PPE and practice of hand hygiene, promotion of healthy lifestyle and managing pre-existing illnesses, early detection through disease surveillance by conducting symptom screening in entry and exit, monitoring of health status, and immediate contact tracing. Detected cases should be reported to the local government and regional epidemiology and surveillance unit to assist in the response and coordinate laboratory testing. Identify dedicated isolation facilities in order to immediately isolate and quarantine cases and close contacts, and treat by coordinating transfer of severe and critical cases to hospitals. Next. The DOH disseminated an interim guidelines on the prevention and control of COVID-19 in prisons and detention facilities. The IRR of mandatory reporting of notifiable diseases and health events of Public Health Concern Act was revised, which includes jails to be involved in the disease surveillance and response. Next. Jail staff reported cases detected through consultation and contact tracing. With the assistance of local government units, confirmatory testing was done on site. Jail officers were trained on proper collection and submission of NPS, OPS, and PPE donning and doffing. Face masks were distributed to PDL and jail officers. PPE were made available for healthcare workers. Isolation facilities were established through the help of the ICRC. Streamlined the coordination between RESU and hospital for efficient transfer of severe and critical cases. Next. There were cases still detected in jails, but this has decreased since August. Jail C last reported a case in June, and Jail A in October. As of November 4, Jail B still have active cases. Next. Let me end my presentation with a reminder. In our pandemic response, no one should be left behind. Next. We would like to acknowledge the following. Maraming salamat po.
Thank you, Dr. Kasmira Maramag, for your nice presentation, and congratulations on your presentation. It's a very important study. So it's a containment area, so it's very likely to spread the transmission. So good work. So we have a couple of questions from Bina Rai. One question is, how many inmates roughly in each jail?
In each jail. Well, for Jail A, there are about 3,000 prisoners or PDL. In Jail B, around 26,000, and Jail C, 2,000 or 3,000.
Okay, so there are a couple of questions. I think these are common. Like one question is there any changes taken by the jail authority to improve the living condition in the jail? And similar questions like how are the jail compliance with this recommendation? So can you please answer this question?
Okay. For the living condition, they are planning to expand the jails, but this is a long-term plan. And then for, what's the other question?
The other question is, so is there any changes taken by the jail authority to improve the living condition in the jail?
Okay, since physical distancing is hard to maintain, so they distributed face mask and soaps so that they can practice hand hygiene, and so that they can control at least slow down the transmission of COVID-19. And there's also the law on good conduct and good conduct time allowance. So they actually prioritized the ill and the elderly who have showed good conduct to be released to decongest the jails.
So one question is, what is the outcome of this recommendation? So is the current case number in these jails reduced?
Yes, as you can see on my slide, 25 cases reduced since August, and we have seen a decreasing trend. So Jail C reported their last case in June, while Jail B reported their last case in first week of October.
Okay, thank you. So we have a couple of more questions, but we are running out of time. So I will take some of the questions. So one of the question is, was the factors with significant odds adjusted for any possible confounders?
We use the stepwise multiple logistic regression to control for the confounders. So that's out of the 19 associated factors known to COVID, we reduced it to six factors.
Okay. The question is, it seems like the outbreak took a few months. Do you have any explanation why it took so long time? From Wana Hanswarakul.
Okay, if I take you back to that time, our case definition for disease detection on that time is those who have travel history, and because jails are a closed setting, we are not really expecting that the outbreak will happen. So and traditionally our disease surveillance reporting units are health facilities or health offices or Center for Health and Development. So these jails are before they're not really reporting their number of diseases or seen in their jails. So that's why the guidelines now, as seen in our slide 23, it was revised that the mandatory reporting included jails and prisons.
One more questions from Taiwan FETP, Angela Huang. Did you see other outbreaks in jails? So there are.
Yes, after.
Yeah, please go on.
Yes, after this investigation, another fellow of mine studied the jails in another region, and there are other reported jails also with clustering.
Okay, another question from Angela. So it's sort of my question thing also this, because your conclusion was the rapid spread of infection was due to high congestion, and I was wondering that do you think any sort of recommendation to reduce the congestion on the jail? So do you want to recommend anything? So the question is like that way, that it looks like that you have identified sharing meals as a risk factor. Was there anything that could be done to prevent disease spread through sharing together?
The PDL were advised to limit their congregation because they were accustomed to share meals with their gang mates. So due to COVID, they were reminded and educated about how this disease spreads. So they were advised to at least limit their sharing of meals. And actually, it was also in the guidelines that we recommended the staggering of mealtime so that they will not congregate. Different cells will not congregate while eating. And that's it.
Okay. So thank you, Dr. Kasmira Maramag, for your nice presentation. I think a round of applause for all the presenters from me and from the team that for your nice presentations. I would like to congratulate all the presenters and the enthusiastic participation of the audience during the discussion session. Thank you so much. I would like to thank our organizer, the FETP Taiwan, and the whole organizer for successfully organizing this conference. And with this, I would like to conclude our presentation session. And I would like to hand over my microphone to Dr. Wan Chin Chen for further process. Thank you all.
Thank you, Dr. Rabbani, and thank you all presenters today. So we are going to close our today's session. So see you next day. See you tomorrow at the same time. Thank you.